questions, but we have to move on. María Heimisdottir is next on the agenda. She is the Chief of Finance and Health Data in the University Hospital of Iceland.
Good morning. My name is María Heimisdóttir. I'm the CFO of our university hospital here in Iceland. It may be strange to some of you to have a CFO talking about use of medical data, but my job is not to save money, but to find ways or help find ways to use the funds that we get to provide as much quality care as we possibly can. All right. So I thought it would be prudent of me to give our international guests just a little information about our health system. We are, as you know, a tiny island nation, 326,000 souls. About 2/3 live here in the capital area. We have a national health insurance where only about 20% of the healthcare costs are paid out of pocket. When I say only, it's probably low compared to what many of you are familiar with, but it's still considerably higher than it used to be before our economic depression. We are the only university hospital in Iceland. We are also the largest organization in Iceland with close to 4,700 employees. We are I guess a mid-sized hospital. We have about 40 medical specialties, obviously many more subspecialties. One of our strengths is that our doctors train in many different countries. In most cases we do not have enough volume to provide specialty training locally. But we consider this a strength. Most of our physicians are trained either in Scandinavia or in the US, with a handful coming from the Netherlands or the UK. There are very few patients sent abroad for treatment. Fortunately, we are able to provide most treatment here in Iceland, either by our own providers or by importing expertise from our friends in Scandinavia usually. Occasionally, we get physicians from the US to work with us on specific cases. We have enjoyed good clinical results, and I'll get to that later. We do serve approximately 1/3 of the population. That's very unusual, I think, for a single hospital to have such a vast coverage. And we serve approximately 1,500 students a year. I guess this challenge is familiar to all of you in here, but it's especially difficult here in Iceland. We have a very large baby boom generation, and this is the line for the 75+ part of the generation. And in the next 10 years or so, which is nothing, it's a blink of an eye, 10 years in healthcare, this portion of the population will increase by close to 40%. This is what we call our frequent flyers in the hospital. And we have our hands full at this moment, and honestly, it's difficult to foresee how we are going to provide the same level of treatment and the same quality of care without finding new novel ways to provide that care. We also have our share of chronic diseases, and this is the burden of illness that we estimated in our inpatients. That's the blue line, I believe, yep. And in our outpatients here in the red area. An 11% increase among the inpatients, almost 70% among the outpatients. This is corrected for the quality of registration. This is actual increase in the burden of illness. And we know that the cost of care increases by a factor of 3 to 5-fold after the age of 65. And 65% of all healthcare costs are related to chronic diseases. That's probably close to 95% among the old. So basically, we have the same problem as most Western countries, that the demand for care is rising much, much faster than our gross domestic product. And so more of the same is basically not an option. We need to find new ways to provide the same level of quality of care, basically to preserve the care that is needed. I picked up one example yesterday when I was speaking to our orthopedics colleagues. and that is this. This is a fairly anemic pointer. I apologize for that. Hip arthroplasty. We're doing 400 procedures now. And let me see, 2025, the demand for this will have increased by 33%. But that is not all. The problem is that some of those will be revisions of older arthroplasties, and they are 45% more expensive. 45%. These are the costs of hospital medications, what we call hospital medications here in Iceland, so drugs like this, chemotherapy, medications for autoimmune diseases, MS, HIV, etc. The yearly price level is the blue line, and you see our economic depression happening here. But still, even if you look at the fixed price level, this is not sustainable, not for any nation. Obviously, as a minute population, we have some specific problems. Orphan diseases or the very rare diseases that require exorbitantly expensive medications, they weigh more in a small nation than they would in a larger nation. Here we need to rely on close cooperation with our neighbors in order to secure patient safety and quality of care. Also in order to ensure the availability of medications. Just securing that we actually can buy the medications. And I'm not just talking about the cost of the medications, but also the willingness of some drug companies to actually sell their high-tech meds to a small nation like this. We have suboptimal utilization of resources. In my MBA studies, we used to say something like this is a non-profitable cost center. Well, Iceland is a non-profitable cost center. We're just too small. There's no way that we are going to be an efficient unit in terms of almost anything. And we do have, sorry, I thought you knew this. We do have serious problems in terms of recruiting and retaining healthcare staff. I mean, it's difficult enough in terms of our economic conditions, but we also must be able to offer, for instance, our new physicians who have been training abroad, we must be able to offer them at least comparable opportunities for research and development. It's just a fact of life. You don't have to like it, it's just reality. Then we have this challenge. This happened October 6th. 2008, when the Prime Minister asked for God's help on state TV, and then this happened. This is what happened to our GDP. It basically went south. And we're still recovering. So this is the background of what we are dealing with in our healthcare system, providing more care at the same level of quality and safety. But the funds are not increasing, they're in fact decreasing considerably. So I'm going to tell you our story in the University Hospital, how we have used data to try to cope with this. And I'm not going to focus on clinical use, and I'm not going to focus on utilization of data for research. I'm going to focus on how we're using this to make decisions at the macro level, how we're using data to run the hospital and making sure that there actually are services to be had. And this is not something that we invented. There are some pretty formidable names that have been providing us with examples to use. These are some of the ways that we're using healthcare data. Along with financial data for decision making in the hospital. We are obviously trying to support our managers from day to day with good data. We are doing a lot of work in terms of predicting demand and also in terms of predicting our future supply of manpower. That's quite a challenge. We have done a lot of cost reduction projects, and we're doing some quite intricate analysis to choose among those projects, to prioritize them, to estimate the expected effects. Basically, we model a lot of the changes that we do. We set up rationalization projects, and then we model their expected effects. And all the while, we are monitoring patient safety, quality, etc. And finally, we are using these same data to prioritize the new projects in terms of hiring new staff, choosing among the different medical equipment that we are purchasing, and also to prepare for our new building. Basically, we're using two approaches for data-driven management. We're using a fairly sizable data warehouse where we house both clinical, financial, and staffing data. But we're also using dashboards and online reports for our staff and managers and for the executive team to watch the overall operations of the hospital. And these are data based on real-time data. So we have the data that have already been gathered here in the process of providing care, but then we also are using online real-time data from the EPR and in some cases from our warehouse. This is an example for the executive team's dashboard. We start every executive team meeting by looking at the patient safety indicators and patient flow indicators, and that has made a tremendous difference in terms of really making people internalize their responsibility. We are all responsible for patient safety, not just the clinical leaders, but also those who take care of the physical plant, finance, etc. And here we have the dashboard that we view. We also have just one more example. We have a dashboard in the ER representing workload, patient flow, patient safety, and this has proved tremendously important. This is a schematic view from the IT division on the sort of setup of our health informatics, and we have a composite EPR. And we are siphoning data from that over to our clinical data warehouse every night, and also from our financial systems and our staffing systems. We have a fairly conventional interface on the data warehouse. It's a drag and drop interface. We have really emphasized the quality of data that we house in there. We do all sorts of quality checks and data cleansing, data labeling, etc. But this is important. What is the access? What happened with access to data? Basically, nothing happened in terms of access to research data. You still need to go through. I mean, if you need those data for research, you have to go through the IRB and the Data Protection Authority, etc., etc. So there is no leniency given there. It's only coded and numerical data. There's no text. Obviously, the Data Protection Authority has been watching this, and we have had very good relations with them. Like I said, when we export data for research, you have the ethical board and the Data Protection Authority overseeing that. We do store the data with a personal ID. Obviously, that can be removed. Analysis at the patient level in-house in the hospital. That is only by designated staff. All of those analysts have background in healthcare professions, and we define access very carefully for each analyst with time limits and specific confidentiality agreements. Clinical leaders have access to their own patients. So if you're the head of endocrinology, you have access to the endocrinology patients. But that's just the same access as you would have in the EPR. You don't have any other access. Obviously in the dashboards there's no patient level data. Just to give you real brief some use cases, we're doing a lot of regular reporting to the management team in terms of quality and volume and costs and all of those good things. We have a fairly intricate cost analysis system that has been extremely helpful in the last years. And we also have detailed utilization data, for instance, for medications and diagnostics. Obviously, this is mirrored in the research data. It's basically the same data, but access to data for research is unchanged. Some use cases, we're doing a lot of benchmarking, especially for the extremely expensive medications. This is a recent example where we were benchmarking our use of TNF-alpha inhibitors with the other Nordic countries. And we're doing a lot of forecasting in terms of future demand. Our cost analysis, here is a heart valve operation, and as you can see, we can look at all of those costs. We can drill down to the cost of the imaging services related to that particular patient. This is patient-level data. This is information on a single patient. Obviously, the ID has been removed. Doing a lot of work on patient flow. Here's an example from one of our lean projects where we are trying to identify bottlenecks in terms of patient flow. And we have timestamps for where the patient arrives at the ER, when he arrives at the OR, etc., etc. So we can measure that. And basically, our story is that in the past, well, since 2008, we have cut 13 to 23% of the operating costs of the hospital without reducing production. Obviously, the data, well, they have been tremendously helpful in terms of being able to cut costs without sacrificing care. But obviously, that's not the only thing. But I think it's fair to say that we would not have been able to preserve the care for our patients in the way that we have without finding new ways to utilize the data. These are data on our academic research. This is before the economic collapse. These are data issued by the Nordic Council. Hopefully we'll get some new numbers soon. We worry a bit that we will not be at number one of the Nordic University Hospitals. But let's see. We've been there since the year 2000. And to this point, we have not seen dips in our patient safety, and I just put one measure of patient safety up here. But obviously this is something that the Director of Health has been watching very closely as needed. So I guess our conclusion would be this. And this is what we're talking about today. But I think the responsible take-home message has to be that we cannot provide and secure access to safe and quality care without finding ways to use those data in a responsible manner. Thank you.
This is also to show that the data can be used for other purposes than research, which are very much research focused in our work. But, are there questions from the audience to Maria on the use of health data in the University Hospital? I think that you are urging for comment, but
yeah. So thank you, Maria. So in the new proposed healthcare law or healthcare research law that is being in the Parliament, there is a clause for a database to use for research and querying for before you go for the ethical. Is your data warehouse going to be used for that purpose?
We could do that. Yeah, and we have sometimes done that. You're talking about feasibility analysis.
Studies, yes.
I'm interested in studying this. What would be the potential pool of cases? Something like that? Yeah, we can do that. Yeah, absolutely. But I should add, though, that the way we have set this up, you as an individual researcher could not do it. You would need to contact the division that is responsible for the data warehouse, and they will do it for you. Yeah.
But just, I think, very brief comment. I think we have to be somewhat careful when we are saying that the cut down of 23% has not been done without any sacrifice. I think we all agree that we have been borrowing from the future with regard to recruitment, training, and so forth. So it's been an extremely difficult time. And I mean, I think the data has helped us a lot to do this, but at the same time, we have to be careful to remember that we have been borrowing in the future.
I think you're absolutely right, and that's why I harped on the importance of being able to recruit people, because that's sort of what we worry most about at this point. What I said, that we have not reduced the volume of services, and that I stand by. And Fortunately, we have not seen, the quality go down. But you're absolutely right that we have been borrowing from the future in terms of recruitment and facilities, absolutely. Yeah.
Two questions.
Do I understand it correctly that researchers get access to your data without patients being asked?
No. We're doing it the exactly same way as you described. There is an ethical board.
Yeah.
If you want to do research, you will hand in your application to the ethical board. And the Data Protection Authority, if they approve, if they provide the substitute informed consent as you described, yeah, then they will get data.
Yeah, but do you try to get informed consent from the patient in the first line? That is the ethical requirement. It's not to say, well, you know, we don't care, we have an ethics committee, and so we ask only the ethics committee. The ethical challenge is to ask the individual first, and only if that is not possible or totally impractical, then to go to the secondary solution. Do you do that?
No, we're doing it in the same way as, for instance, was described from the Serum Institute, that we have an ethical review board, both internal and external. And so this is epidemiological research, and we are following the traditional decades-long methodology. If you get, obviously you do not get data with the personal identifiers on.
Oh, it's de-identified data.
Yeah.
It's anonymized.
Yeah.
That's something different.
Unless there is a special reason for you to need the identifiers,
Yeah.
which is seldom. But then there's a whole different process.
Yeah.
Yeah.
There are a lot of issues that we are working with need to question from the back.
Yes, just a follow-up question to the first question here. You mentioned the feasibility studies, which are obviously anonymized. So it was put in the question in context with the bill that's before the Parliament now. Just to clarify, do you see anything, or do you in practice have anything that is in the current legislation a hindrance in doing those feasibility studies today?
No. You can do those feasibility studies, and I think actually I had an example here of hereditary polyneuropathies.
Exactly.
This is an old example, where we just responded to the question, I mean, is it feasible at all to study this in Iceland or not? And that was a simple answer. I don't even know if the study went on.
Thank you.
But there are, I've seen, and Thorvarður knows a lot about this, there are applications where you can do feasibility studies in, I guess, a much more elegant way. You can look at much more than just the number of diagnoses. And in some cases, the researcher can do that himself. That's not a priority of ours. I mean, we have plenty of more important things that we're working on now.
May I clarify here? I mean, I think the individual researcher cannot access this data for a feasibility study.
No.
So that's different.
No.
The hospital can maybe
We can
access the
provide
data.
you that service.
But you
Yeah.
wouldn't provide it unless you would, with the current legislation, you would not be able to do a feasibility study without the ethics committee approval beforehand. So I think that's the whole point of the new legislation, to do a simple feasibility on numbers without any identifiers, just to ask whether the study before you go to the ethics committee.
No, I was emphasizing the fact that the researcher himself cannot access these data and do it. But I know that there are cases, right? There are applications that would offer that.
Okay,
I can just say simply yes. I think you've explained this very
Yeah.
well. That we're moving with this new legislation from a more cumbersome process to a simplified process in the cases where we are only requesting patient counts, no actual identifiable, not even any
And no actual data.
unidentifiable data on the patient, no, just simple counts.
Yeah.
okay, we have a very short coffee break, so we will gather here in 15 minutes from now.